Oktay, başlayalım mı?
Bence başlayabiliriz. Tabii ki.
Tamam, bence sen istiyorsan İngilizce mi yaparsın, nasıl yaparsın bilmiyorum. Bir genel bir giriş yapıp sonra bence şeyle başla. En güzeli sen yap. Bence başla
Ama,
artık.
hocam siz istiyorsanız girişi yapmak isterseniz siz başlayın. Yoksa ben konuşma açılış yaparım. Ya
E,
ben, okey. Ya da hepsi.
Olur. Yani
Nasıl?
Türkçe istiyorsan ben şöyle çok kısa bir şey söyleyeyim. Sonra sen İngilizce şeyleri
Tabii ki. Tabii ki.
işte.
Tabii ki.
Evet.
Süper.
Herkese iyi akşamlar. Bu Erişkin Doğumsal Kalp Hastalıkları Derneği'nin bu toplantısı ilk defa yurt dışından yabancı konusunda uzman konuklarla yapılmaya çalışılacak. Bu konuda Oktay Bey'e çok teşekkür ediyoruz. Konuşmacılarla hem konuları hem konuşmacıları çok iyi bir şekilde ayarladı. İnşallah yani eğitimimize katkısı olur diye düşünüyorum. Ben sözü Oktay Bey'e vermek istiyorum. Oktay Bey, buyurun.
Çok teşekkür ederim. So I will switch to English, and so it's also my pleasure to welcome you all to this first webinar. It's first of its kind, but hopefully not the last one. And our topic is imaging of the right ventricle, and we have two fantastic speakers. Unfortunately, our first speaker, Elena Zokova, had to cancel last minute, but this leaves us more time for discussion, and I'm really looking forward to the talks of our fantastic speakers. The first one is Annemien van der Bos from Erasmus University in Rotterdam. Annemien is an expert cardiologist by training. She's a cardiologist. She's an expert in adult congenital heart disease and pulmonary hypertension, and also in echo imaging, especially in imaging and echo imaging. She has a large track record of publications and has kind of supported and looked out a lot of PhD students, does a lot of research, is a very important person in this field, and we are really happy to have you here. And it's an immense pleasure to have you here. And I mean, thank you very much, and the floor is yours.
Well, thank you so much for the kind introduction and also for the invitation to talk to you today about the right ventricle. I must say, I thought Elena was before me and she would talk about all the different parameters of right ventricle. So I changed my topic a little bit to transposition after arterial of atrial switch and the congenital corrective transposition. But I will also talk about the right ventricle. So I will share my full presentation. I hope it will start. Give it a second. And I hope you now see it all. And maybe I can get rid of this. So this is a good, I'm not sure if I can get this out of the picture. Yes, that's better. I want to show you one important paper that can really help you in imaging patients with adult congenital heart disease. It's actually a paper from Wiley from the Brompton, as he was the first author and was already published in 2018. But the nicest thing it is, when you scroll all the way down in the supplementary, you have imaging protocols. As you see here, especially on the right side, telling you exactly what you can see with every view you obtain. So here for a subcostal view, the apical view, and here you see all the different parts and segments you need to evaluate in that specific view. That it can really help you, especially standardize your echo protocol in your own center. So let's start with just the transposition of the great arteries and the different operations that we have had in history. Because in the adult population, we still have quite a lot of patients after atrial switch operation and a mustard and a setting operation. But yes, you can't hear me? Oh, I thought somebody said something.
Yes, we can hear you.
No, you can
Okay.
continue. Everything's
Oh,
fine.
thank you. So we have a different population at the adult outpatient clinic, as we have still patients after mustard and senning, and also now because I think the last operations have been performed in around the beginning of the 1990s, and now we only have arterial switch patients. But this the group is quite big and are now all in their 40s, 50s, and have a lot of problems, especially right ventricular dysfunction. So I would like to show you all the different complications we face in this patient population. And I will show that in a patient story to go all these different complications. So we start with a 43-year-old man who was born as a blue baby and found to have a detransposition of the great arteries. Here, this very typical sign of the parallel arrangement of both the big vessels. So in 1981, he first had a atrial septostomy, and then a mustard correction was performed. And this was a baffle that was made by cortex of Dacron. A setting procedure is actually has the same way of directing the blood, as I will come forward, but now in a sending procedure, the tissue is used from the right atrium and the atrial septum, and that is used to redirect the blood flow from here, as you see, the caval veins, inferior and superior caval veins, is directed to the right atrium and to the right atrium and the left atrium and left ventricle, and the pulmonary artery is going to the right atrium, right ventricle. Easier is that to see in here is a picture of an MRI. And most important, we have to remember that the pulmonary venous flow actually starts posterior and then goes to anterior of the inferior baffle. As you see here, it goes all around, starts at the back, posterior, before the superior tunnel, goes around into the right ventricle. And this pulmonary venous return is actually one of the landmarks that you can easily visualize with all different modalities. And this is how it looks with echo. So when you lose your track in this kind of hearts, I always say follow the blood flow. And let's start here with this subcostal view. Here, entering of the pulmonary veins. Here, the baffle leads the blood to the right atrium, tricuspid valve, and right ventricle. If you look at from an apical point of view, we again here see the pulmonary arteries, pulmonary venous atrium, going to the right atrium, tricuspid valve, right ventricle. So this really can be used as a landmark that you don't lose track. So the caval vein supply, the deoxygenated blood, actually enters behind. Here, goes into the left atrium, mitral valve, left ventricle. So these are important and you start, and especially if you don't know the history of your patient, when you make an apical 4-chamber and you see this line inside, let's say, the atrium, you always know there must be here an atrial switch operation. So if we continue this patient story, at the age of 25 years old, there was an obstruction of the inferior baffle. And how do you get this inferior baffle best in your echo view? Well, if you start again from a apical 4-chamber and you angulate, as you see it, you get more to posterior, then you pick up the inferior baffle. And here is it from a normal baffle. You see it's quite open. And here, if you turn around, you in a short axis view, I will guide you through this image. You have the inferior tunnel, the inferior caval vein with the inferior tunnel going here to the left side. This is the tricuspid valve and the right ventricle. And here you see the color. As I told you, this patient had an inferior baffle obstruction. And again, we have here that same picture as I showed you in the previous slide. We have your inferior caval vein. You already see here the narrowing of the baffle. And also when you put color on it, you see, especially here, you see the turbulence and the higher velocities when you put your Doppler. And when you do a tracing of your Doppler pattern, you see a mean gradient of 10 millimeters mercury. Not only this is a sign of baffle obstruction, and also, of course, you see the turbulence and a narrowing of your grayscale image. But what also really can help you if you're not knowing what is happening is looking just at the size of your inferior caval vein. When that one is dilated and it doesn't collapse, then you must always look for a baffle obstruction. So we did a balloon dilatation here, especially exactly on the place where the obstruction, and that obstruction was relieved. Sometimes a balloon dilatation is not only, sometimes you need also a stent implantation. So the inferior baffle is actually easier to image. When you go to the superior baffle, it's actually more challenging. And what can help? Actually, the majority of our patients, especially above 40 years old, will have a pacemaker because of sinus node dysfunction. And your lead coming from the superior caval vein can help you actually look for the superior baffle. So here in this parasternal long axis view, you see the pacemaker lead here, and that I'll go back, and that you know that this must be coming from the superior caval vein. As I said, it can be difficult to really look and find the baffle's obstruction in the superior baffle, but if you put in the Doppler in your superior caval vein, it can already help you visualize if there is indeed higher velocities. For the pulmonary venous obstruction, the best way is to look at, again, this apical view, and I'll guide you through it. Here, as you see, is the tricuspid valve with the right ventricle, right atrium. Here is your pulmonary venous atrium. And here you see at this level, we see already there is an obstruction with turbulence here. Again, in your Doppler evaluation, you see much higher velocities than you would expect in a venous return. It's going up to 2.9 centimeters per second. But it's not only the absolute velocity, more importantly, is also looking at the pattern. So what are the key criteria to diagnose a pulmonary venous obstruction? That is a elevated velocity more than 1, but it still runs back, and that is a really important part, still runs back to the baseline. If it's above, that can, but it still raises going down to the baseline, there's only a mild stenosis. When you see a Doppler pattern like this, that it doesn't go towards the baseline, then you have a significant stenosis. And also it has a continuous flow and it never returns to baseline. So what we always say, the waveform is actually more important than the absolute velocity. So he was relieved of his baffle obstruction, and we continued, and he did pretty well for a time. And then he came back, and we put him on a bicycle. In the Netherlands, we all cycle, and doing a cardiopulmonary exercise test. And it was done to screen for desaturations and arrhythmias. And actually, it revealed I had a baseline saturation of 92% with room air oxygen, but there was a significant decline of the saturation to 86 while cycling, and there were no rhythm concerned. So often you need to do that because you need to know if there are any baffle leakages, because often when these baffles were created, we see small leakages that can actually also grow with time. And in this patient, a small baffle leak is not a problem. But when these baffle leaks get bigger, and especially when the venous pressure then rises, as for example in exercise, this shunt that is present, and here is this as the deoxygenated blood goes into the oxygenated circulation, then you can have a significant decrease of oxygenation in your blood. So this is an example. Again, I will guide you through. So you start here. This is the inferior caval vein coming into the inferior baffle. And this leads towards the left ventricle. And here you already see a gap, but especially with color, you see here there is a little bit of a bidirectional, but more a baffle. So the deoxygenated blood runs into the right ventricle. And that is an important sign. And if it is symptomatic, you need to close it. And in this patient, we closed it with an ASD Amplatzer device. So if you summarize the baffle problems in these patients, we have a systemic venous baffle obstructions that is often seen in a mustard operation. The pulmonary venous obstructions are more seen in the Sinning operation. As I told you, small baffle leakage are very common and often not hemodynamic important, except of course when you have a stroke. That could be a reason then to also close small leakages, but especially large leakages that can also have volume overload, but especially the deoxygenation, desaturation during exercise is actually one of the important signs of a significant baffle leak. Here are the percentages. We see often more superior and inferior baffle obstructions. As I said, small leakages are very common, but sometimes you need to do a reoperation when there is, if you can't close it with a device, you need to consider reoperation. So at that time, he thought he was doing so good that we lost him for a few years from our follow-up. And ultimately, he presented at our local emergency room with an atrial flutter and a very rapid ventricular rate, as you see here. And he had a cardioversion back to sinus rhythm. That was all went well. But of course, when you put a probe on his ventricle, he had now a really a poor right ventricular function, and you don't even need any measurements for that. Just by eyeballing, we're already seeing here this right ventricle with a poor contraction and some mild tricuspid regurgitation. So we have all kinds of ways that we can assess right ventricular function in a normal subpulmonary ventricle, and here you see a few of them. I will start on the left side of this of the screen, and it is the TAPSE and the TDI. But you must remember that TAPSE and TDI are both only measurements for the longitudinal function of the right ventricle, and it actually also tells you only a part of very local information, as TAPSE is only the information from the movement of the tricuspid annulus towards the apex, and TDI only tells you about the velocity of the myocardium just above the tricuspid annulus. So it's very local information, and it's only information given from the longitudinal direction. However, we also know that this systemic right ventricle, when it's actually very long, need to endure very high pressures, its contraction pattern can change towards a more circumferential movement. And when we see a reduction of the longitudinal movement, because we see our TAPS and TDI go down, it not always needs to mean that also the whole right ventricular function goes down, because sometimes the right ventricle compensates when there is more circumferential movement. Another form that is now more often used is right ventricular strain. And right ventricular strain, especially of the free wall, but you can also use it for the whole ventricle. And this right ventricular strain gives not only local information, but actually gives information of the whole ventricle. Unfortunately, there are not really normal values for this, and it's not as we can do with the left ventricle when you have your standard 3, 2, and 4 chamber views. Actually, for the right ventricle, we only use this apical kind of 4 chamber view to assess right ventricular function. And again, also this strain calculation is only the longitudinal motion that you assess. So if you truly want to have an idea of right ventricular ejection fraction, we need a 3D modality. And you can use 3D echo. However, we all know 3D is challenging, but if you practice it and you do it a lot, you will get better in it. What can you do in your own echo lab? As you know, we have a lot of different parameters that you can assess for right ventricle. But for the systemic right ventricle, this was a really nice overview looking at the feasibility and looking at the validation. And when you put in all different parameters for the systemic right ventricle function assessment, and I mean strain, TDI, TAPSE, right ventricular fractional area change, 3D, if you put them all in there and you go from literature to daily clinical practice, in this really nice paper of colleagues from Leiden, they showed if you look at global longitudinal strain, fractional area change, and just eyeballing this global systemic right ventricle function, that those are actually the parameters that are most feasible, because that's also important, feasible and also most validated. So we also recommend to use these parameters for the assessment of the systemic right ventricular function. Of course, you can add TAPSE, TDI, and all those other measurements, but at least try to use these two and add, for example, TAPSE and TDI for the assessment of this systemic right ventricle. In our center, just to let you know that there are other possibilities, we use a form from what we call iRotate. And actually what we do is assess the right ventricle as you would think it is a left ventricle. For a left ventricle, we have very strict views to assess it, the 4-chamber, 2-chamber, 3-chamber. And this is set for the right ventricle with iRotate. You put a probe on the apex of the right ventricle, so you a little bit slide towards the right. Here, we start with our, let's say, 4-chamber view of the right ventricle. Then we turn. Here you see the grades. You turn to a more 2-chamber image, and then you turn further, then you come here, the aortic valve comes in, and here you have a kind of a 3-chamber view. And in this way, We standardized that. In this way, we try to actually catch the right ventricle on a very protocol way in every patient, so you can assess the right ventricle on a little bit more views than you would normally do, but well, all from this apical point of view. A last part that I wanted to mention with the systemic right ventricles, because when they're going to fail, they, it not always is easily found. If this right ventricle goes down, because they have this moderate function for many years. But one of the signs can be the presence of pulmonary hypertension. A left ventricle is often very small and we say banana shaped. And also here we see a form of left ventricular obstruction with a SAM here present. When you have a poor ventricle and elevated right ventricular pressures, always look, of course, if there is a baffle obstruction, but very often this pulmonary hypertension is a result of right ventricular failure. And when this pulmonary hypertension is present, please always start immediately with heart failure medication. But also, this is a sign that the patient is in a next phase of heart failure. And actually, if you can't get the pressures down, don't wait and continue going to advanced heart failure therapy. And that is a lesson we have learned, that we often wait too long, and then assist devices and even transplant are not possible anymore. So don't wait, and please continue to evaluate patients for FAT therapy, assist device therapy of heart transplant, especially when you see the first signs of pulmonary hypertension. So it can also be a challenge to evaluate the pulmonary hypertension, but of course you can use your, as we do it in normal hearts, your mitral regurgitation jet, so the velocity of the mitral regurgitation. But maybe easier, that is looking at this left ventricle. This left ventricle, as I said, is always small, it's banana shaped, it always almost completely squeezes itself out. And when it starts to dilate, that can be one of the first signs for a pressure or volume or volume overload. Other signs that you need to look for are especially the pulmonary regurgitation, as you see here. The pulmonary regurgitation, when you have high velocities of pulmonary regurgitation, and also the Doppler pattern of the flow over the pulmonary veins, as we know in normal forms of pulmonary hypertension, are parameters for elevated right pressures of pulmonary pressures. So right ventricular dysfunction is one, but please always look if there are signs of pulmonary hypertension. And if so, continue to do invasive measurements and get them on heart failure medication. So let's continue to the congenital corrected transposition. And this actually is pronounced in many different ways. We have it is the CCTG8, so it's a double discordant, it's L transposition. So we have a lot of different ways to address this congenital corrected transposition of the great arteries. But actually, it's a little bit simpler than I just talked about, because the only thing that really has changed is the left and the right ventricle, and the rest is everything the same. As you see, the right ventricle now supports the systemic circulation, and the left ventricle supports the pulmonary circulation. And that makes life a lot easier, because you don't have to visualize all these difficult baffles with these obstructions and these leakages. And also, I have just set the record. I had a patient who was 91 years old, doing great, was actually protesting that she had to come to the cardiologist because her children wanted that. And she actually had a CCGA, and she was 91 years old and actually doing very good. So maybe we are missing a lot of these ventricles because patients, not often, but they can get very old without symptoms. So this is an example of a congenital corrected transposition. And as I already said, it's often mistaken, for example, a patient with non-compaction cardiomyopathy. But if you carefully look, you immediately see here that this valve, the tricuspid valve, is more a position towards the apex. And you know this is a tricuspid valve and a mitral valve. And also here the moderator band is clearly visible. The same is true as we saw in patients with an atrial switch operation. You see this very small left ventricle that is also banana-shaped and squeezed against the right ventricle, this big dilated right ventricle. If you turned around, visualize the aortic valve, we see sometimes abnormalities in this aortic valve, not so often, but don't forget the aortic valve when you turn around. And we evaluate this right ventricle in the same way as I discussed with you with patients after atrial switch operation. So it doesn't really matter if it's a CCGH or a atrial switch operation patients, we assess the right ventricle in the same way. And again, the strain and right ventricular ejection, right ventricular area change are the two main parameters, added with longitudinal parameters as TAPSE and TDI. In these patients, we have to be aware of the tricuspid valve regurgitation. And the difficulty is that we also have often abnormal tricuspid valve. It can be like Epstein malformation can be present. And this can also, of course, influence importantly our right ventricular function, because as you see here in this patient has a severe right ventricular regurgitation, tricuspid valve regurgitation, and we underestimate this right ventricular function in this patient. And you can already see that this valve is really abnormal. It sticks a little bit, it's thickened. So you not only have a ventricle that can give dilatation, because and that is the reason of the regurgitation, but you can also have this abnormal valve that can also make the regurgitation even earlier than it is only from the dilatation. This is an example of a patient with an Epstein. And if you want to look at the regurgitation, I like to use biplane imaging. This tricuspid valve is difficult to assess fully with 2D, and you need to visualize it from different angles. And putting in a biplane image, you have more control over your second image, as you see here. So here in this line, the correspondent image in this line is here. So it's perpendicular to each other, knowing you that you know exactly that you visualize the valve in this level, and you see it here. And then if you put in the regurgitation, if you only would put it here, you wouldn't see the full extent of the tricuspid valve, tricuspid regurgitation jet. So you can evaluate the tricuspid valve by using biplane imaging and even using rotation of it to really understand the severity of the regurgitation. This is just an example. If you just angulate the 4-chamber view, Here is the left ventricle angulate to the pulmonary artery. Here the pulmonary valve with the branches to the pulmonary artery. And it's again the angulation of your probe to mere anterior. And here you see the aortic valve coming in too. So I hope I've showed you a few examples of what you can expect in patients with ventricular transition after arterial switch operation and also in the CCGH. Imaging is challenging, but as I say, please follow the blood flow. And if you do that, you can go from the inflow to the outflow through the whole heart. In patients after atrial switch operation, know that there is still a ventricular arterial discordance, and we know there are even very late after sending a mustard operation, we have potential complications as in venous pathway stenosis and leakages, but especially this right ventricular dysfunction and development of tricuspid regurgitation are more of a concern in the patients getting over 40, and especially the ones who suffer from pulmonary hypertension, because when that is present, we really are in a different stage of heart failure. I would like to thank you for your attention, and please, if you have any questions, let me know.
Thank you, Annemie, for this fantastic talk and this comprehensive overview, and especially for your tips and tricks how to image all the
Tabii, evet. Herkese iyi akşamlar. Bu
there was some okay, so I think someone replayed the beginning.
Okay.
So it was kind of so it's very interesting to see how you image the baffles. I think that's always challenging, and it's always difficult also to teach to young fellows, because it's very hard to imagine the 3D model. So thank you for that. Are there any questions from the audience? Maybe I have to speak up because I can't see every hand, to be honest. So if you have a question, please go ahead.
Maybe raise your hand.
Yeah, maybe probably these.
May I ask the questions? May I ask a question? Yes. After the arterial switch operation or corrected transposition, some patients come with severe tricuspid regurgitation and right ventricular dysfunction. What's your criteria about directed transplantation or tricuspid valve replacement? I'm a cardiovascular surgeon.
Yeah, well, that's a debate we often have. It's all depends a little bit on a few factors. First, of course, again, is this what is the mechanism of the valve regurgitation? Just to have more an idea of this right ventricular function. It's not written in the guidelines, but when I see a valve that especially has dilatation, and that is the reason because of the regurgitation, I'm always a little bit cautious, because it is already a big sign that this right ventricle maybe is too far away, for heading into more transplant direction than a replacement. So I'm always a little bit cautious, especially in the transposition after atrial switch. I'm cautious to repair it or replace it. When there is a transposition of the great arteries, a corrected transposition of the great arteries, and you have like an abnormal Epstein valve, we often do replace it, and patients will gain better from that. So there's really two different, in my opinion, two different identities that you see. You mustn't put all them together, because there are really different congenital heart disease patients. So for the CCGH, I'm more frequently going for valve repair, or for valve replacement. We don't repair them anymore. And in a atrial switch operation, we often continue to transplant. Is that a little bit a question, answer to your question?
Yes, I think so. May I ask you something? I still see people using Simpson's EF calculation and apply it to the systemic right ventricle, especially with the newer machines where you have kind of this manual EF calculation, which is very handy. Could you comment on that?
Don't do it. No, you know, the Simpsons calculation is really based on a mathematic formula, and that is done for an ellipse form of a left ventricle. And unfortunately, this right ventricle will never be catched in any geometric formula. So I think it's not a good idea to do that. I do believe that for example, fractional area change can be used, but doing a Simpson on a right ventricle, I don't think it's a very good idea.
Thank you. Wholeheartedly agree. And probably reply down this to talking to my fellows.
And I have a question.
Yeah, please go ahead.
During the, sometimes the surgeon must switching to pulmonary bicuspid valve or the neo-aortic valve. In this case, what is your protocol for evaluating this kind of case, like a bicuspid aortic valve or this knee, because there is a knee problem, because you have a bicuspid aortic valve or neo-aortic valve in this case. What is your protocol for the evaluation?
I must say we don't have that a lot of problems in a atrial switch operation with the aortic valve, I must say. We don't have specific protocols for that. And so what we do see, but that's maybe, I'm not sure if is that what you mean? We sometimes see that the pulmonary valve can have problems, especially the SAM that is caused by the mitral valve. That can sometimes be a problem, and even getting very high gradients there. And that is also has been a sign that we might need to address that more earlier than we used to do. But I don't have a lot of in my practice, but maybe Oktay has, I don't see a lot of aortic pathology in these patients.
Yeah, it's quite rare, but I think maybe I'm mistaken, but the question probably alluded to the arterial switch and the bicuspid aortic valve. Correct me if I'm wrong, who asked the question, but something like that. I know of one or two cases in our TJ court after atrial switch who have kind of a problem with the aortic valve, which is probably related just to age. We would probably see it also in general population, but I think the question was more to, could it be to atrial switch? May I ask the person ask the question?
Yes. Sometimes we have some kind of problem of aortic root, neo-aortic root dilatation, and the huge aortic valve dilatation. And in this case, it is indicated, we discussed sometimes, is there any indication for the beta blockade therapy or other kind of aortic root reservation operation? It is our actual problem, some different case.
Yes, I understand. In the arterial switch, yes, we see neo-aortic root dilatation, and it is a debate because many say, well, it's not that a problem, and you don't have to be that cautious because when it is 50 millimeters, for example, you don't have to address it immediately because you have a stitch on top of it. But we are see actually time often help us decide, because when you have this dilatation, you also have valve regurgitation. And actually that is often the main reason to to go for an operation, and then you take the route with it. So most of the times, if it's not too big, we will wait till the valve also needs an operation.
We have also a question from the chat. What is your opinion on understanding the radial or circumferential contraction of the right ventricle by evaluating the motion of the anterior wall of the right ventricle using M-mode echocardiography?
I don't use M-modes anymore, but I still love M-mode. It's I think one of the most unvalued image modalities we have. You can use M-mode. I don't have a lot of experience, I must say, for evaluating the right ventricle function. So I haven't done it many times. I'm sorry, I can't really comment on that.
I can ask a question. Hi, Annemin. Thank you very much for very detailed speech. As an expert echocardiographer, using the new tools, when do you refer the patients to MRI? Because normally you check everything with echocardiography, the systemic right ventricle and everything. And then do you believe the new tools, using the new tools, measurements are somewhat equal to MRI, or what do you think?
I think you can follow the patient very well with echo. But there are a few important rules. Do it always the same way, so you can compare. The patient is his own control. So use the measurements that you, and it doesn't really matter if you use everything or only a few, but use it in the same systematic way every time, every year time you echo this patient. We do MRIs, but not that often. I do it like once in 5 years maximum, I think. And of course, when there are problems. So when I see a strange deterioration, or if anything really goes abnormal, I will do it more frequently. But I don't do it every year because it's also just not the capacity, the availability of MRI. And I think we all know that. So a proper, good echo evaluation can really help you. You don't need MRI all the time. That's my opinion, but I'm an echo person.
Okay. So how much experience would be nice to do that? So
how many patients you would need
yeah, how many patients, or I think you believe to do in regular way, always the same methodology.
Yes.
In every patient.
So yeah. So but I really believe that have a protocol. So as we work in our hospital, we have a standard protocol. So all our sonographers know to do it in always the same way, also in the same order. And for me, because I know these protocols and I look at the echoes, I also know exactly, I never forget anything because it's so systematic. And because we are doing this so systematic for almost more than 20 years, sometimes adding, of course, things, I can really compare the echoes from 20 years ago and now, because it's so systematic. Then when you are so systematic, your sonographers and also yourself will gain the experience much sooner, I think, and much easier, because you have this standard protocol that you can hold on to.
Thank you.
May I have a question?
Yes, of course.
Thank you very much for your comprehensive talk. I'm an adult cardiologist, seeing some congenital patients. So most of the times, patients with systemic RV have some sort of dysfunction. And I've seen some patients very poor RV, but doing clinically pretty well. So in your experience, how well do you think the RV systolic parameters are related to clinic?
the functional state as well. That's very important. I completely agree that it now always adds up. But be careful, because these patients are used to their right ventricle. So they have never experienced the same exercise capacity as other people with normal hearts have. So they already have an other threshold. So when they tell you there's nothing happening, they're feeling fine. But if you put them on a treadmill, or if you put them on a cycling exercise test, then you really see that they're doing pretty poor. So that is the reason also that you really have to challenge them to see how symptomatic they are, because they will not tell you.
Thank you.
Totally agree. And most of the time, these are the patients who run into trouble in the next 4 to 5 years. These are the patients who got a lot of problems, even if they're asymptomatic or kind of asymptomatic. And I mean, fantastic. You showed all what you do and what you can do, and you have your protocol. How long does it take to do such an echo in a mustard patient or a thinning patient? So your experience, but in your experience, and then when let's say a previous fellow.
Yeah, but we take 45 minutes. I'm not sure if that's something that is familiar, but we take 45 minutes. Yeah.
I think that's very important to point out. I think it's doing a good echo on an ACHD patient takes time. Even a very experienced hand, it takes time. And I think that's very important for all of us to remember during our busy outpatient clinics. We most of the time don't take the time, don't have the time due to different circumstances. But you can't do all these things if you don't take the time for it. That's very important. Are there any other questions? Oh, there's one in the chat again. Let me see. When is the exact time to address the golden single RCA in an ACHD patient with a failing systemic RV? When do you start surveillance of the atherosclerotic risk factors for these patients?
Well, that's a very good question, and as it actually intrigued me in the last few years. We have never really done it until they're around 45 and above. But I now have actually, I think we have learned from our mustards. And my personal theory is, and it hasn't been really in the literature, but I think we have abnormal flow patterns in the right coronary arteries, and probably more shear stress. And I think that arteriosclerosis is probably more frequent than we think in these mustards patients. So we did it above 45 years age, but with our knowledge now and seeing more coronary artery problems that I would expect with that age of the patient, I'm now going down, and I'm already screening them earlier. And it's not really a set number, but we really start earlier, 40, maybe even 35 years old, because I really think we are under treating them now at this moment.
Absolutely. Great point. I think, and that's, I'm an adult cardiologist as you are, and I think we often concentrate only on the heart defect and on the repair, and we don't look at all the other comorbidities which our patients acquire, and they are not immune to that. Like the general population. So if you have an obese patient with hypertension who's smoking, then you should probably check his cholesterol just to make sure that you don't miss anything. And I think it's very important to remember that our patients are getting older, and your group, and Julien's group in Rotterdam, has shown that beautifully how old our master patients are getting. And it's very important to remember that they all acquire comorbidities, as all the rest of us do. And it's very important to check for them. So it's a very important point, I guess. Are there any other questions? You see a lot of discussions going on. I mean, it's
That's good. That's really good.
May I ask you something? So you said there are no gold standard or no normative data for the strain data you derive. So do you use the same approach, or would you just delineate it that you say, I look at the patient individually and see how was the strains last year and then go on? Or do you have some kind of departmental scores where you look at, or charts?
No, of course you can use the normal values for the subpulmonary right ventricle, but it doesn't add up. So I always use the patient as his own control and see what happens. It's just actually because they all have lower TAPSE and TI, it's just always low.
Yeah.
Any other questions from the audience? Let's see, is there some? Oh, so the last question, the last person said thank you to you. So,
okay, well.
If there are no other questions, I would also like to give you a big thank you and a big applause. We can't applaud here, but
Okay. Thank you so much
for this fantastic talk and for this fantastic overview. It was an immense pleasure to have you here as one of the, may I say, because it's the truth, the world-leading experts in echo and ACHT. So it was fantastic, and I always learn something from your talks. So thank you so much for being here with us. And so I would like to continue with our next speaker.
I'm saying goodbye to you. Thank you so much that I could meet you today here online, and hopefully we'll see each other in another part of the world, maybe in a congress. Have a very nice evening, and thank you, Oktay, again for the invitation.
Thank you.
Okay, bye-bye.
So we have talked about echo and what all echo can do, and that we maybe don't need MRI. I'm sure that our next speaker will not continue with this finding. And it's also a great pleasure to have here Inga Voges here. She is a professor for pediatric cardiology. She leads the outpatient clinic for ACHT in the University of Kiel, which is in the northern part of Germany, and has an historically large congenital heart disease program. And she's also head of MRI, and she trained also at the Brompton. So we are part of the Brompton family from London. And she's a leading expert regarding MRI and congenital heart disease, has published a lot on different topics, and is always at the edge of the new technology. So we're looking forward to your talk, Inga. Thank you for joining us, and the floor is yours.
Can you hear me?
Yes.
Thank you, Oktay. Thank you very much for this kind invitation and in the introduction. And it's a great pleasure for me to give this talk today. And what he has already said is that I am a fan of MRI. So, and I would like to show you the various methods that we use nowadays and that help us to assess the right ventricle in congenital heart disease patients. So I would like to start with some background information. Then I will show you the various CMR techniques and clinical examples. So as you all know, function and size and structure of the right ventricle are associated with the outcome of numerous cardiac diseases. As a congenital cardiologist, I, of course, think about tetralogy of Fallot. As we know, these patients have an increased risk for ventricular tachycardias, and they have an increased late mortality. And one of the major risk factors is RV dysfunction. Unfortunately, the right ventricle is, although we have seen it differently by the previous speaker, is not that easy to assess. And we are looking for the ideal imaging method that unfortunately does not exist. But I have listed some variables that define the ideal imaging method here. So of course it should be comprehensive and reproducible to assess the RV morphology, function, hemodynamic parameters, and it should be also able to characterize the right ventricular tissue. And what else? It should be available quickly and everywhere, secure and cost effective. So MRI does not fulfill all these criteria, but it has a certain amount of strengths, and they are listed here. So it allows us to assess the RV anatomy and function independent of acoustic windows. It has a good reproducibility. It is extremely versatile, and new methods and technologies are coming around every time. It can be performed during pregnancy. It does not have any ionizing radiation, and pacemakers and ICDs are no longer contraindications. However, it is relatively expensive. Expertise is not available everywhere. Also, that becomes better. Artifacts due to implants can be a problem. MR scanners are not transportable. MRI is relatively time consuming. Also, some studies can be done in 45 minutes, similar to extensive echo studies. For some patients, sedation is needed. However, I think overall, the strengths outweigh the listed limitations. I will now show you the various CMR techniques that we do in routine clinical practice and actually in nearly every single patient. CNA imaging is the workhorse of MRI imaging. And when it comes to the right ventricle, we are able to assess a volume-loaded right ventricle, as this can be seen here in a tetralogy of fellow patient with pulmonary regurgitation. Sometimes you can already visually see that a patient is a ventricle is pressure-loaded. This was a patient with pulmonary atresia and a stenosis of the homograft. And of course, CNA imaging also allow us to assess the anatomy. Here you can see an atriosecundum septum defect with mild dilatation of the right ventricle. CNA imaging is very easy to acquire, and it also allows us one of the most important parameters. So we can get the volumes of the right and left ventricle that are reproducible, and we can get also functional parameters such as stroke volume and ejection fraction. Typically, these parameters are measured from a short axis stack, as you can see here in a patient with CCTGA and dextroversio. We can also use CNA imaging to get strain values. This is a more new method. It is called feature tracking, and it follows anatomical markers throughout the cardiac cycle. And when we use a 2D feature tracking method, we can get strain values for the, can get the longitudinal strain values, as you can see here, but also circumferential from the short axis stack. However, it has some disadvantages, and one point I would like to let you know is that it has a limited spatial resolution through plane. CNA imaging also allow us to assess great arteries. When it comes to the right ventricle, of course, we want to know what are the pulmonary arteries like. Here's an example of a patient with pulmonary hypertension and a massively dilated main pulmonary artery. Here you can see the branched pulmonary arteries surrounding the ascending aorta in a patient with transposition of the great arteries after arterial switch operation. And this is a patient where we assess the pulmonary veins, and this patient has a partial anomalous pulmonary venous drainage with an enlarged right atrium and right ventricle. So CNA imaging can give us a lot of information and is very helpful when it comes to CMR. The other technique that is or that should be part of every single CMR study is phase contrast flow assessment. With this technique, we are able to measure blood flow. Most often, 2D phase contrast flow assessment is performed. And it is based on the fact that moving spins in the blood vessels generate a phase shift within the magnetic gradient. And to a first approximation, this phase shift is proportional to the speed of the spins. With 2D phase contrast assessment, we are able to measure stroke volumes. Here you can see a phase image that was acquired above the aortic valve in the ascending aorta, and there we can measure the stroke volume of the aorta. We can assess regurgitation volume and are able to quantify valvular regurgitation. We can measure flow velocities, we can quantify cardiac output, and we can quantify shunts. This was a patient with right to left shunt with a QP to QS of 0.6. 4D flow is becoming more and more popular. It is a method that is an extension of the normal 2D phase contrast flow measurement, and it allows us to measure blood flow within a 3D volume that we can define. So we acquire a 3D volume stack with ECG gating and respiratory navigator, and then we are able to measure blood flows within the acquired volume wherever we want with certain post-processing software. And that allows us to visualize flow patterns, as you can see in this patient that had mild coarctation and that was found to have by CMR more than mild tricuspid valve regurgitation that can be seen from the 4D flow data set very nicely. We can get some information about flow velocities with color coding. And some studies have shown that 4D flow is actually better than 2D flow and more equal to echocardiography to measure peak velocities. We can quantify flow parameters similar to 2D phase contrast flow measurement. So we can get cardiac output, stroke volumes, we can assess QP to QS, but we can also measure new parameters that give us some information about hemodynamics, or some more advanced information about hemodynamics, such as wall shear stress, pulse wave velocity, kinetic energy, and others. Beside flow assessment, typically every CMR study includes some angiographic acquisition. Normally nowadays, we do not perform contrast-enhanced MRI anymore. We acquire more and more often 3D data sets. And here you can see a 3D Dixon sequence that is of, I think, quite good quality, and that even allowed us in this patient to get some information about the course of the coronary arteries before interventional pulmonary valve replacement. So we did not need a CT scan in this patient. Myocardial tissue characterization, I've already mentioned this. This is a very important technique. I not often do this in every study. So when a patient comes for repeated CMR scans, so I not always give contrast agent. So I always try to avoid giving contrast agent. But when a patient has not had contrast agent maybe for 10 years or has been lost to follow up, or if it is his first study, then I normally perform a late enhancement imaging. And this is based on the fact that in fibrotic tissue, there is a slow washout of the contrast agent, and it stays longer in this area and then can be seen as bright areas, as you can see here in this patient, within the myocardium. Another technique that allows us to get some information about the myocardial tissue characteristics is mapping. You might know that we perform T2 mapping and T1 mapping in patients with myocarditis. This allows us to assess myocardial edema and to get some information about inflammation. In our congenital heart disease patients, we normally only use T1 mapping to get information about fibrotic changes, the so-called diffuse fibrosis that we measure with the mapping techniques. I would now like to move on and would show you some clinical examples because I think that is the most important and most interesting. I would like to start with tetralogy of Fallot. These patients are probably the group of congenital heart disease patients that are most often get CMR scans. And as I have shown you, CMR is very well suited to assess the right ventricle in these patients. And with the flow assessment and the volumetric measurements, we can produce good data to assess them if they need a new pulmonary valve when they have important pulmonary regurgitation. In this patient, you can see on a through-plane flow image that there is significant pulmonary regurgitation. Also, you can see here that this patient had a tiny residual ventricular septal defect. This was not hemodynamically important. Quantification of pulmonary regurgitation can be done with 4D flow or 2D phase contrast flow assessment. In this patient, there was a moderate pulmonary valve regurgitation with a regurgitant fraction of more than 35%. The forward flow was 8 liters per minute and the backward flow 3 liters per minute. Probably you ask yourself, is 4D flow better than 2D flow in quantifying the pulmonary regurgitation? I would say we do not have enough data, but the data that are available show that they are probably equal and that we can use both 2D and 4D flow. Recent studies have included MRI data to assess if the criteria that we use from the MRI studies are really valuable in assessing the patients and in the timing of the pulmonary valve replacement. This is a large multi-center trial that was published last year and that included more than 1,000 tetralogy of Fallot patients. I think that is actually the biggest study ever. And they used the common criteria from MRI that say, oh, we should replace the pulmonary valve when the right ventricle has an indexed end diastolic volume above 160 or 180, and if the end systolic volume is above 80 or above 95 milliliters per square meter. And they found that the patient benefit from pulmonary valve replacement when using these criteria, and that the outcome was better compared to those patients that met the criteria and did not get a new pulmonary valve. So we actually can rely on these criteria, but we should not operate, and that was another message from the study, we should not operate or intervene too early, but because those patients who get a new valve earlier than the criteria we commonly use, they do not benefit from an intervention. Myocardial tissue characterization can also be clinically important. In this study, the authors looked at patients who had ventricular arrhythmias compared to those who had not ventricular arrhythmias, and they found that those with a large scar, as you can see here, actually have more often ventricular arrhythmias. So myocardial tissue characterization can help you in prognostication. Commonly, these patients have, the tetralogy of Fallot patients have scar tissue in the areas or in the surgical areas, such as in the right ventricular outflow tract when they have a large RVOT patch or transannular patch. But sometimes we see also late enhancement unexpectedly in the left ventricle, as you can see here on the mapping image. So overall, it makes sense at some point to use contrast and to assess the amount of scar tissue. And in this study, the authors actually have very nicely shown, that study was published by the Brompton Group in 2022, that the amount of scar tissue is important for patient prognosis. I would now like to have a look at shunt lesions, because they are often overseen and they can present quite often late in life with an enlarged right ventricle. Here you can see an example of a patient with an atrial septum secundum defect. And we measured the QP to QS from the phase contrast, 2D phase contrast images. This is another commonly overseen disease, a sinus venosus defect. So this was a lady, 81 years old, who was followed by cardiology for nearly 20 years. And in the clinic letters, it said, oh, this lady has a funny RV disease, and the sinus venosus defect was actually not seen. She then presented to adult cardiology in our hospital, and they did a cardiac catheterization for assessment of tricuspid valve regurgitation. And they were surprised by their measurements and told us, oh, there is probably a shunt. And we performed an MRI scan because echo was very difficult. And we already saw on the first images that this is likely a sinus venosus defect. Here's a large defect, and on the short axis images, you can see here the left atrium, the SVC coming down here, and there's a large defect. This lady was treated interventionally with stent placement into the SVC, and her right ventricle came back to normal. She had, as assessed by MRI, a mild leakage, but is now back into sinus rhythm, interestingly, after many years of atrial fibrillation, and is doing much better. Sometimes CNA imaging is not always so easy. And in this patient with a large right ventricle, we were first not sure what this is actually we see here on the CNA images. But in the end, it is a partial, a very unusual partial anomalous pulmonary venous drainage. You can see here the entire right-sided pulmonary veins draining in one vessel deep down via a tunnel to the right atrium, whereas the left-sided pulmonary veins drain normally into the left atrium. So 4D flow not only helped in blood flow measurement to get the numbers QP to QS, it also helped to get some information about the anatomy. And the surgeon told me that this assessment was correct and that the information we got from MRI and the results from the report were correct. I would now also like to have a look at the systemic right ventricle in patients with TGA after atrial switch operation. You have already seen the echo assessment. MRI is often very helpful because sometimes the echo windows are very poor and we are not limited to acoustic windows, and we can nicely see the buffets. You can see the pulmonary venous buffet draining here to the atrium and then to the right ventricle. And here's a systemic venous buffer. We cannot see them here, but they come here into the left atrium and the left ventricle. Also in this patient, tissue characterization can be of importance. Sonia Babunarayan from the Roy Brompton has done a lot of work in this field in assessing fibrosis in various congenital heart disease patients. And she also looked at patients with TGA after mustard or sending procedure and found RV fibrosis in up to 61 study participants. And here you can see an example of a patient, and you can see that there's a thinning of the RV inferior wall and some akinetic area. And this is in the late enhancement images represented by scar tissue. And on echo imaging, often this is not well seen. And I'm sometimes often surprised that I see more scar tissue than previously expected. The same group, also Sonia and a colleague from Sweden, looked at patients with a systemic right ventricle after atrial switch operation, and they found in a very nice setup that those patients with positive LGE have a less good outcome compared to those who do not have late enhancement. So it makes sense to look at the replacement fibrosis and to assess these patients with MRI. In a similar setting, they found that myocardial fibrosis is also related to the synchrony, tricuspid regurgitation, and dysfunction. In a recent study, the authors looked at the more common MRI parameters so that we actually get from every single study, and that does not need contrast agent application, so the volumetry. They found that simple parameters such as the right ventricular end-diastolic volume index can be of prognostic importance. They found in patients with CCTGA and in mustard sending patient that an increased RV and diastolic volume index above 130 is associated with a less good outcome. So coming to the end of my talk, I can actually probably say that MRI is a very versatile method. We not always need contrast, and we can keep studies to the most important parameters, and we can, in that way, if we have the capacity, do it more frequently than every 5 years. We can actually go to every 2 to 3 years. We can do shorter studies just for assessing the RV size and function. And maybe in future we can do it in a similar way, like not completely like echo, but my hope is really that we can come to the point that we use it in a short study more often and get more prognostic information for our patients. So this is my take-home message. CMR is accurate and reproducible for assessing the RV size and function. It allows us to get excellent anatomical illustrations with good resolution, and we can avoid sometimes CT imaging even when it comes to assessment of the coronary anatomy. We can do blood flow measurements in a 3D volume with excellent reproducibility. And we can get information about prognosis that allows us to risk stratify our patients better. Thank you for your attention, and I would like to mention our CMR course that will run in London in October 2024, and you can come to London, but you can also assess or you can also join the course online because it is a hybrid course. Thank you.
Thank you, Inga, for this great talk and great presentation and about the strengths of MRI. Maybe you could stop sharing, then we could see all. Fantastic. So it's easy to see everyone. Are there any questions from the audience? Yeah, we have the first one from Dr. Attic. Please go ahead.
Hi, dear Inga. Thank you very much for your excellent presentation. I want to ask two questions. One is about RV function in Epstein patients. How do you measure the RV? We know that in Pittsburgh group, who always perform COM procedure, they only measure functional RV. But in the literature with Mayo Clinic, they measure the atrial chamber. Or in some literature, they perform tricuspid valve replacement index. What do you think about this in Epstein patients? And the second question is about almost adult patients with partial anomalous pulmonary venous return. We calculate in MRI the QPQS. Also, we perform cardiac catheterization for these patients. For example, only one pulmonary vein returns to the incorrect position. What do you think? MRI is enough? No cardiac catheterization? Can we follow up these patients with only MRI? Thank you.
Thank you for these questions and nice to see you. Patients. So I always measure the RV volumes from a transaxial sinus stack that I have not shown here. So I would not measure the RV from the short axis stack. And we typically look at the total left and total right. What is it said? So we compare the total right side compared to the total left. Then, of course, we look at clinical parameters. There's not a single measure that really tells you what is the best strategy in these patients. Of course, we measure a variety of parameters, but when it comes to decision-making in them, it's always very difficult, and we do not rely on a single parameter. And regarding the anomalous pulmonary veins, I think depending on the clinical picture, it might be enough to just go for MRI because you can get all the anatomic information you want. You can get the QP to QS. Of course, if there's a suspicion of increased pulmonary vascular resistance or pulmonary hypertension, then you need the cardiac catheterization. But typically, MRI would be enough for us.
There's a question from.
Thank you.
There's a question from Dr. Duman in the chat. She thanks you for your excellent presentation, and she asks, when do you start to take an MRI, and in which intervals do you suggest cardiac MRI in patients with operated phallopterology? Is fibrosis a risk factor for cardiac arrhythmia in these patients?
So if the patient is clinically well, if on the echo images the RV is not massively dilated due to pulmonary regurgitation, we normally would say when the patient has reached an age and is able to undergo the MRI scan without any sedation or general anesthesia and is without too much stress for the patient, we just wait and do the scan with 12 years, 14 years. So that is typically, in my experience, in many patients enough. We rarely see patients with massively dilated right ventricles before that age, but of course this can be the case, and then we should rely on the echo images, and then we should go for an earlier scan. But normally it's fine to wait until they have reached an age where they are able to undergo the scan without any stress. So stress for the child and without sedation. Regarding cardiac arrhythmias, yeah, there are some studies, as I have shown, that large areas of scar tissues, especially in the right ventricular outflow tract, especially in those patients who are already older and have got large RVOT patches in the past, they have a really increased risk for life-threatening arrhythmias. And in those patients, when they plan for pulmonary valve replacement, we would perform an EP study before these intervention or surgery.
I have a question. You showed the data for late gadolinium enhancement in systemic right ventricle patients. How often do you really use that clinically? I mean, it's established to use LGE for fellow patients. We probably all agree on that. But how often do you really use it for systemic right ventricle in your clinical practice?
It is well known that due to hemodynamic reasons, they can have, like in patients with pulmonary hypertension, they can have RV fibrosis. So that is more commonly seen, probably commonly due to hemodynamic reasons. It might also be when they have undergone after atrial switch operation surgeries, it might be also related to previous surgeries. But also in CCTGA patients who have not undergone surgical procedures, we also see RV fibrosis. And so I would do it in a patient that comes for the first scan. And if there is no clinical change and the scan is maybe more than 5-6 years, not more than 5-6 years later, then I would not do it again. But in the first scan, I would probably do it. I would give.
May I just ask an additional question before Tevfik ask you a question? How often does that change your clinical treatment of your patients?
Assessing.
So if you see fibrosis on the MRI in a systemic right in a mastered patient, does it change your way of treatment or anything, or is it?
It can change the treatment because often maybe not that much, but it gives you more information why maybe a ventricle is not that good, why it might be more stiffer, and it might change your heart failure treatment. I think it can be helpful. I think it's important in my opinion, and it has been shown that that it is related to ventricular events.
I just alluded to the fact that there's a study from Sonja, but I think there's not just as robust data out there for, I don't know, for the indication for an ICD or something like that, like it is in the Roger fellow. So I think we should be a little bit more cautious. But Tevfik has a question. You're still on mute.
Thank you very much for your excellent talk, Inga. I like it very much. I just have a concern and question about if in case of chest cage abnormalities like pectus excavatum, when the chest cage is compressing to the right ventricle free wall, then I feel that evaluating the right ventricle volume and function might be difficult. How do you solve this problem? Even with MRI study, I feel that this is misleading us. I mean, in terms of determining the volume of the right ventricle and function. What do you think about it?
It should normally not give us wrong data because you get a full stack of the right ventricle, but of course it might be more challenging to get the appropriate views. And often the heart is then more shifted towards the left chest. So it lies, in my experience, often more towards the left chest, depending, of course, on the patient's anatomy. But I don't think that it changes the. So it should not have an impact on the volumes and the measurements.
Okay.
But maybe if you have more patients of this group, then you can perform a study and give us more information.
Okay.
You pointed out that pacemakers are not as much as a problem anymore. Where's your limit? I mean, yeah, sure, we have artifacts, that's true. But how's your policy, for example, for epicardial leads?
We are actually cautious with that. So we do not put patients into the scanner. Also, during the last CMR conference in London in January, there was a very nice talk where they were not that cautious, and they showed that typically this should not be a problem with having, of course, safety things in place and being, do not scanning patients without all the safety measurements. But typically, this will also create large artifacts. You need to have appropriate sequences that allows you to get good images. So I'm not sure if this is always necessary to put these patients into a risky situation.
Are there any further questions from the audience?
Can I ask something?
Yeah.
Hi, Dr. Wag's very nice presentation. I would like to ask something. First of all, we can show the localized fibrosis in patients with tetralogy of Fallot, but in the past they used extracellular volume to find the fine fibrosis inside the ventricular myocardium, and then, but I don't hear any news about these days. What do you think, especially the fine fibrosis beyond the localized fibrosis, because it can cause the rhythm problems and heart failure in future. And another thing is the normally coronary anatomy well documented with the CT angiography, but you said MRI angiography also can be used. And then almost all patients do use the MRI scanning for the coronary anatomy. This is the second question. Thank you very much.
So the first question regarding ECV, yes, this is typically measured with T1 mapping. I have not mentioned this. We do it routinely. Unfortunately, there is not much data. So there are not much studies on T1 mapping and diffuse fibrosis in congenital heart disease patients. Also, those studies that are available in smaller cohorts have shown that it might be prognostic if you have an increased extracellular volume fraction. And in case I give contrast, then I always would do T1 mapping and would measure ECV as well, because you do not need to give extra amount of contrast agent. Might be helpful. It is easy to acquire and actually also easy to measure. So I would always do this on top. The problem is you need actually normal values for your scanners. So you need to have collected normal T1 values for each of your scanners, for each new MRI environment. They are different from 1.5 Tesla to 3 Tesla. So that makes it a little bit challenging. And I can say for our 1.5 Tesla scanner, the values are quite comparable with those from the literature, whereas for the 3 Tesla scanner, they're completely different. So we need to collect, or we needed to collect numbers for the 3 Tesla. So that is really a challenging situation. And also you need to be very careful when measuring RVT1 values, because if it's not a hypertrophied right ventricle, you might measure as a blood pool and get wrong numbers. So in pulmonary hypertension patients, it might be good, but in those with a SYNT RV, I would be very cautious. And regarding the coronaries, we do a lot of CT scans as well, but in some patients, the quality of the 3D data set, like we use the 3D Dixon sequence, that is of, I like the sequence a lot. It's of very good quality, and we get good information about the coronary anatomy. And typically we would go for a CMR scan first. Yeah, and would look at the coronary anatomy. And often this is enough before pulmonary valve replacement.
Thank you so much.
Are there any further questions from the audience? If not, I would like to thank Inga again. It was a fantastic talk. It was a great pleasure to have you here on this first webinar. It's always good to listen to the leading experts in the field and to learn. And I would like to thank the ACHD Association of Turkey for organizing this webinar. The audience, we had more than 70 participants the whole time, which is a great success, I think. And especially, I would like to thank Alpay and Tevfik for organizing this event. And I hope many webinars will follow. And I would like to invite my co-chairs to close the session. So Alpay.
Yes, evet, ben o zaman Türkçe konuşayım. Sen İngilizce konuştuğuna göre. Ya ben de teşekkür ediyorum. Çok güzel bir organizasyon oldu. 2 konuşmada bence yeterliymiş. Çünkü sorular çoktu. Ancak yani yetiştik. Ama devamını bekliyoruz. Yani bunu planlayalım ve istekler doğrultusunda yeni konuşmalar, yeni paneller, webinarlar oluşturalım. Tevfik bu konuda çok çalışıyor ve tabii ki İlker dernek yönetiminde ve diğer yönetim kurulu arkadaşlar. Herkes yani bu konunun önemli olduğunu bildiğimiz için ben de yardımlar için tekrar çok teşekkür ediyorum. Hakikaten iyi bir organizasyon oldu. Çok teşekkürler.
Bir de son bir iki cümle ben ekleyebilir miyim? Bu bizim grubumuza katılmak isteyen arkadaşlarımız varsa eğer bir chat hazırladı Hakan sağ olsun. Bu anketi de doldurursanız seviniriz. Bir de gruba katılmak isteyen yeni arkadaşlar olursa lütfen o arkadaşlarınıza da bu anketi paylaşın. Hani grubu büyütürsek iyi olur herhalde, değil mi Alpay abi?
Evet, evet, bence de süper olur.
Hepinize geldiğiniz için, tartışmalara katıldığınız için teşekkür ederiz. I would like to thank to Dr. Inga very much. I appreciate your efforts and your talks. Thank you very much.
Pleasure to be here.
Okay, bye bye.
Hakan, senin söylemek istediğin bir şey var mı?
Yok, teşekkür ediyoruz. Çok teşekkür ederim.
Anketle alakalı.
Yok, anket yani şu an yollanıyor. Bir de ayrıca bizim gruba bir link yolladım. Hani grup içinde olmayan diğer katılmak isteyen başka doktor arkadaşlar da o link paylaşılırsa biz oradan verilerini hem WhatsApp grubuna hem de mail grubumuza ekleyebileceğiz. Bizim Erişkin Doğumsal Kalp Hastalığı Derneği'nin WhatsApp grubuna o formu tekrar yollayacağım. Oradan da o gruba üye arkadaşlar diğer arkadaşlarla, diğer doktorlarla paylaşabilirler.
Oktay, sana çok teşekkür ediyoruz
Ben teşekkür ederim.
desteklerin için. Bir sonraki toplantı için artık herhalde gelecek haftalarda konuşur bir plan yaparız. Biz yine Kasım ayı sonunda, Aralık başında şu 2 günlük toplantımızı yapmak istiyoruz. Orada da yine sizden desteklerinizi bekliyoruz. Onun için arayacağız sizi.
Evet, teşekkür ederim. Evet.
Evet, herkese iyi akşamlar.
İyi akşamlar.
İyi
İyi
akşamlar.
akşamlar. Hoşça kal.
Bye bye.
İyi akşamlar.
İyi akşamlar. Ercan, iyi akşamlar.
Abi iyi akşamlar. Çok güzel toplantıydı. Ellerinize sağlık.
Sağ ol,
Oktay
sağ ol.
Hocam teşekkürler.
Evet,
Ben
İyi
teşekkür
akşamlar
ederim.
hocalarım.
iyi akşamlar.
Herhalde bundan sonra Oktay hocamızı Türkiye'de sık sık göreceğiz.
Evet, sağ
İnşallah.
olsun bizim kongre için de davet ettim. Kabul etti. Çok teşekkür ediyorum ben. Ulusal Pediatrik Kardiyoloji'de de beraber olacağız inşallah.
Ben
İnşallah.
teşekkür ederim. Davetiniz için teşekkür ederim. Seve seve.
Çok teşekkürler.
Ve tabii ki benim için de çok büyük bir onur ve gurur Türkiye'ye gelebilmek için, bu şeyler için. Ve bence bu webinar da bayağı büyük bir başarıdı. Yani 70 kişiden fazla izledi.
Evet.
Çoğu webinarlar Avrupa bazındakiler bile bu kadar şekilde izlenmiyor.
Evet.
Yani bence
Yani
çok güzel bir
bir ara 80'i geçtik. Sonra